Okay, greetings, Sith and Jedi. My name's Danny Whitaker. As always, this is my own worst enemy, mental health podcast. Is it Sith and Jedi or Siths and Jedis? I don't actually know anything about Star Wars. I've tried watching it a few times, but I can't seem to get through the first 20 minutes of any of them. It's like watching paint dry. In fact, it's worse than that. It's like watching paint that's already dried, and not even coloured paint, just white paint. Dry, white paint. But then again, before you go getting offended, I know this can be a very sensitive subject for some people, I enjoyed Batman vs Superman, like really enjoyed it. So, what do I know? Not only that, but I can also say with zero irony, genuinely, I think Ben Affleck is hands down the greatest Batman of all time. So, one man's meat and all that. I'm just realising, trying to placate the Star Wars fans, I've probably just gone and offended a load of Batman fans now, but never mind. I look forward to the emails. Danny@myownworstenemy.org, if you feel so inclined. Anyway, today is Friday, 12th of May, which puts us at the tail end of Mental Health Awareness Week in the UK. I think it's Mental Health Awareness Month in the US. You guys have still got like 2 weeks to go. But, bigger country, more people, so makes sense, I suppose. So with that in mind, I've got the perfect episode for you today. Today, we're discussing stigma. My guest today is Professor Graham Thornicroft. Graham is Professor of Community Psychiatry at King's College London and Consultant Psychiatrist for South London and Maudsley NHS Foundation Trust. He's also the Chair of Maudsley International. Graham has authored or edited over 460 peer-reviewed papers and 30 books, including the Oxford Textbook of Community Mental Health and the book which kind of forms the basis for today's discussion, Shunned: Discrimination Against People with Mental Illness. In today's episode, we discuss the origins of stigma, from the etymology of the word itself to historical depictions of mental asylums. We draw lines of distinction between concepts such as ignorance, prejudice, and discrimination, and how each of these manifests in the real world. We explore how the media depicts mental illness, how stigma is actually measured and quantified by researchers, the importance of anti-stigma campaigns such as Time to Change and the ways in which they've proved successful. We touch on the recent trend in anti-stigma campaigns aimed specifically towards men. We ask if discrimination is ever justified, and, most importantly, Graham gives a few tips on how people with mental health issues can navigate the potential minefield of disclosure. You can follow Graham on Twitter. He's at ThornicroftG. That's at ThornicroftG, and that's Thornicroft with an I, not a Y. I'm sure you'd like me to mention also the Time to Change campaign. Again, that's so those guys are on Twitter. They're at Time to Change, and the website is time-to-change.org.uk. As always, if you'd like to comment on this episode, you can do so by going to myownworstenemy.org/podcast. If you'd like to support this podcast, there are various ways you can go about doing that. Again, just visit myownworstenemy.org/support. And with all that said, I think what I'm going to do now is go make sure my antivirus software on my computer is up to date, just in case any Star Wars or Batman fans decide to try and hack my computer and empty my bank account. Oh, good luck with that. I think there's only about 30 quid in there. I think that's spoken for. Anyway, as I always say, please enjoy my conversation with Professor Graham Thornicroft. Okay, Graham Thornicroft, welcome to the podcast.
Thanks, Danny.
Here today to speak about a very important topic, one that seems to be part of the kind of the zeitgeist at the moment, particularly in media, and that's stigma with regards to mental health. But before we kind of jump into it, I always like to find out a little bit about the person I'm talking to, and obviously why it is I'm talking to you specifically on this particular topic. So if you could just kind of give us a brief history of yourself, kind of your academic career and why you specialise in this particular subject.
Okay, Danny. Well, I'm located in South London. I'm sitting here on a cold, wet, damp, rainy spring morning in South London.
Yeah.
And if you like, my official title is Professor of Community Psychiatry. Well, what's that mean? What do I actually do? And I do two things. One is I treat patients. I'm a doctor, a psychiatrist, and I work in what's called an early intervention team. That means that we take people in the first episode of having psychotic type problems, and then we treat them for a couple of years to see what's the very best we can do to help people to recover as quickly as possible. But also a lot of the time I do research, and I do research about three things. One is about stigma and discrimination. Two is about what's called global mental health. That's especially mental health issues in low and in middle income countries. And the third thing is about community-based services and how to make them better, how to assess if they work. So one of the big things I'm interested in is about stigma and why. Well, I think throughout my professional life, I've had for a long time a sort of niggling feeling on the back of my mind that it's different from working with people who've got, for example, diabetes or high blood pressure. There's something different about the mental health field. And that got to the point about 10 years ago where I said, I want to look into this in more detail. So I was very lucky because I managed to get a year to stop all my usual work and just to do one thing. I said, I want to write a book about stigma. I want to look into this in a lot of detail. And so I read everything I could about stigma, not just in mental health, but in other areas, people with facial disfigurement, short stature, sex workers, all sorts of things. And then I tried to make sense of it. And in fact, when I read about stigma, I got both very confused because the word means lots of things, but also got very frustrated and angry because it hadn't really led us to understand what to do to get rid of stigma. So I came to a different way of thinking about it. And it seems to me stigma is a general sort of overarching sort of umbrella word. But in fact, there are three different components which are important. The first is to do with knowledge about mental health or about mental illness. And mostly that refers to either ignorance, because most people don't know much about mental health, but also disinformation or misinformation, because a lot of the things that people think they know about mental illness are actually wrong, myths about violence and so on. The second thing is to do with feelings about how we react emotionally to people with mental health problems, either if that's ourselves or if somebody else. And most of the information we have is that's largely a negative set of emotional reactions. And so that's about people's attitudes. And essentially I call that whole set of issues prejudice. And the third thing is to do with people's behaviors, their actions. So if you apply for a job, and if you say something about having now or previously experience of a mental illness, does that make your chance of getting a job worse? And usually it does. So that whole area about people's behavior I call discrimination. And in fact, as I read and thought more about these issues, the book wasn't eventually about stigma. The book was about discrimination. It's called Shunned. And an example of that is that when I was little, I was 3 or 4, my mother had a severe period of depression and in fact needed ECT, electroconvulsive therapy, before she got better. The tablets didn't help her for some reason. And when she went back to work, she was working as a local district nurse. She didn't tell her boss why she'd been off sick. When I asked her more recently about that, she said, I've got to be mad. If I told my boss why I was off sick, then I wouldn't have been allowed to go back to work. So those are sort of behavioral issues which I think are important, issues to do with citizenship, to do with social inclusion towards getting work, keeping work. So for all these reasons, I think that stigma and discrimination is a very important area to focus on, not just theoretically, but very practically about how we can reduce them.
Right, Graham, before we kind of get into the thick of it, I just wondered if you could kind of give us some statistics which kind of maybe paint a broad picture of the situation we're in at the moment with regards stigma, kind of where we're at, how bad it is, broad facts and figures, those kinds of things.
So let's start with a few basic sort of big picture bullet points. And we'll begin with some work we did a few years ago when we talked to several hundred, in fact about 700 people across the world who'd been given a diagnosis of schizophrenia. And we asked them about their experience of stigma and discrimination. These are in all parts of the world. And about 90% said that they had experienced discrimination in their everyday lives. Most often, That was either in the family or with friends or in the workplace, but also other aspects like transport or sometimes financial services or in religious facilities. We then went on in another study a few years later to ask the same question of people with depression, this time in about 40 countries around the world. And now we're talking to over 1,000 people who had a diagnosis of depression. And over 80% said that they had also had experienced discrimination because of their mental health condition. And we also then said, does this stop you doing something? And surprisingly, a lot of people said that they had decided not to try to do things that were important, maybe like apply for a job, because they expected to fail. So we called that, in the sort of research jargon, we called it anticipated discrimination. It's probably better described as why try syndrome, because if you expect to fail in getting the job, then maybe you shouldn't even waste time trying at all. So we think that these issues to do with stigma and discrimination are common in all parts of the world where we've looked, and often they all have severe consequences which exclude people from everyday life.
Yeah, when I was doing the research for this interview, one of the things I found interesting was the kind of the etymology of the word stigma. Correct me if I'm wrong, but it dates back to people being branded for like committing criminal acts. I think in like the 16th and 17th century. Am I right in thinking that that's the root of that word? And
so the word is originally from Greek, and it both applies to branding or sort of putting a mark on somebody's skin with a hot iron, but also to other, stigmata of Christ and so on, other marks which distinguish a person. It's a mark which then has a negative value attached to it.
Right.
So somebody seems to be worse or worth less or belittled by virtue of that mark. Now, a lot of the most influential work in this field was 50 years ago by an American social scientist called Erving Goffman. And he wrote a book called Stigma. And one of the things he said is that you have to distinguish between so-called visible and invisible stigma. And in fact, he put people with mental health problems into the invisible stigma category, not like having leprosy, for example. And he said, and that means that, potentially people won't be recognized because it's not like not having a leg or so on. But of course, it's not as simple as that, because quite a lot of people with mental health issues do fear that they look different, or maybe on tablets or medications which may cause side effects, and they'd fear that those be recognized as indicating have a mental illness. So it's not as simple as either visible or invisible. But you're right that this word goes back a long time, at least 2,500 years, and it's a mark that conveys a lesser value for a person.
Yeah, the reason I brought that up specifically is be quite easy for us to kind of jump straight into like contemporary issues to do with stigma, but of course there's a history of it. I mean, I interviewed a guy called Greg Agigian a couple of weeks back on the topic of the history of mental illness, and obviously historically there's been the maltreatment and kind of misrepresentation of people with mental illness dating back hundreds of years, but also it sounds like a very primitive question, but it's this idea of there being no smoke without fire. That stigma possibly exists for a reason. And so I was just wondering if kind of from maybe a historical perspective, if you could maybe run us through I'm not sure if these are quite the right words, but the justified and the unjustified reasons for the historical existence of stigma.
Well, some people will say that the stigma is one way of seeing a sort of fundamental human characteristic or attribute, which is between those like us and others, so in-group and out-group, and that this is somehow, of essential evolutionary importance, and it's very important that most people will know with whom they belong and who's from a different group and who's a threat. And so for quite a long time, people would say things like this, suggesting that it was such a deep-rooted concept that it might be very hard or indeed impossible to reduce stigma against people seen to be otherly. But in fact, that's wrong. So let's just think about some more recent evidence about whether stigma is sort of so rooted that it's unbudgeable. We know that until the Time to Change campaign started in England, which is 2008, it wasn't the case that stigma was just static and unchanging. Indeed, stigma in England was getting worse for the decade until Time to Change started, because the Department of Health in government, it runs annual public attitude surveys, and we can see this year by year getting worse. This is over the time when there were quite often huge headlines and crazy killer and schizo and axe wielder, this type of thing. And also we've seen from many campaigns now in about a dozen countries that you can make stigma better if you really put your mind to it. So stigma isn't fixed. Now, going back more historically, as you mentioned, Danny, I think it's also in life, it'd be nice if life was nice and simple, but it's not. So while one can say is that the depictions of mental illness going back centuries, indeed millennia, are largely of negative images and portrayals of people with mental illness, that's not uniformly true. And in some places and some times, people whom today we might say have, for example, psychotic experiences, might have been seen as gifted or spiritual or visionaries and would then be given positive social status. So one can't easily generalize about these things.
I wonder if it's something to do with just that sense of intrigue from people, that it's, the imagery of, say, Victorian asylums and the like. It's more intriguing. It's more interesting. It's more entertaining, I guess, almost for people. And so maybe that's why those images are the ones that have been kind of brought to the forefront and that are kind of remembered more deeply, because of course it's that kind of history sort of, I think, it kind of lays the foundations. And I think the stigma of today, that those historical depictions, they have to bear some of the responsibility for that.
So I think there's quite a lot of what you're saying, Danny, that drama and threat seem more interesting and visually portrayed than a sort of placid person sitting doing nothing much of interest. And the not just historically, if you go back to famous pictures of Paris madhouses in the 18th century, Salpêtrière, and people were typically raging and foaming and frothing and in straitjackets and so on. So that was a common way of portraying any mental illness. Interestingly, at the moment, another sort of fashion is that you'll see people, usually silhouettes, people in a dark corner, head in hands, clutching the hands. So that's a current sort of fashion for how to visually show something that's actually quite difficult to get a real picture in your mind about. But I think it's not as if these are just historical things. So we've done work with the police to see whether it's possible to reduce stigma among police officers. And the answer is yes. And it's the same way you reduce stigma with anybody else, is you arrange an occasion for people to have contact, personal, indirect contact between somebody you'd like to reduce the stigma for and people who experience a mental illness. And in this case, what the police officer said was quite interesting. They said, we only ever see people who are mentally ill and in a crisis or an extreme condition. Normally, we're asked to go to a public place to pick up somebody acting in a bizarre fashion and to take them or convey them to a place of safety. And then they said, what was really interesting today when we had these two service users talking to us is they seemed normal. They acted normally. We've never seen people who have said, yes, I have experienced mental illness, who've also been acting normally. So the raging as a stereotype is also common in some groups in our society today.
What about these kind of depictions of people, like you say, going crazy, having to be restrained, etc. It's very obvious why those images are stigmatizing. What about things that might be considered kind of less severe mental health issues, like depression, anxiety? What are the ways that you think those are commonly misconceived and therefore stigmatized?
Well, this is where it gets interesting. You see, if we start with the general portrayals and come on in a second to the violence question, there are very few images which the media use in a systematic and repeated way to convey anxiety. It's almost as if they just don't know how to deal with it because it's such an internal state. And unless somebody's pouring with sweat or actually trembling visibly, it's very difficult to get a sort of handle on what it looks like. Passion, they've got sort of more useful stereotypes. There's the sort of person in the corner, head in hands. There's the tearful person. There's somebody perhaps, contemplating an act of self-harm. But they struggle. If you think about, common conditions like phobias, panic attacks, generalized anxiety, specific anxiety, it's interesting these don't sort of fit into the normal sort of lexicon of media imagery. Now, if you come on to the question about violence, some people say, although it may be exaggerated, there is, if you like, a real basis for stigma because, some people with mental illness are more violent than others. And the closer you look into that question, the less clear it becomes. Indeed, I looked into that when I wrote this book I mentioned called Shunned. So for the large majority of types of mental illness, if we take depression or anxiety or panic attack or phobia or eating disorders or dementia, there's actually no evidence that people who have those experiences are any more likely to be violent than anybody else. Typically, the focus of these discussions about violence comes to people with the diagnosis of schizophrenia.
Yeah.
But when you look more closely there, first of all, this is very uncommon. It's about 1 in every 200 people, and other conditions are actually much more common. But when you look into the evidence, again, it sort of disappears between your fingers. And the hardest evidence, if somebody has a diagnosis of schizophrenia and a diagnosis of antisocial personality disorder, so-called psychopath, and they're using alcohol or drugs or both, then there is a clearly increased risk that people in those three categories together are more violent than the average person. But the numbers in that group are tiny, and one shouldn't then apply that to the whole of the people with, for example, experience of psychosis, because it doesn't apply.
Yeah, I think with, especially with schizophrenia, it's a common trope in like TV series and movies that somebody going around killing people has got schizophrenia. How, like we were just saying about like the kind of the responsibility that has to be borne by historical depictions, how much, I know it's difficult to kind of quantify, but how much of the responsibility needs to be borne by the media for mental health stigma in general, and with newspapers, movies, etc.?
Well, sorry, just to keep going back, this is not an advertisement of my book, but the book's all about stigma. When I was writing that, I wanted to be as sure as I could be that what I said was fair. And indeed, I wrote a whole chapter about how the media relays or conveys or amplifies images and stereotypes of mental illness. And then before I finished the book, I'd drafted that chapter and I sent it to two journalists I knew to say, is this a reasonably fair account of mental illness in the media? And it's interesting. One came back saying, well, you've got a year to write a book, you lucky fellow. But we have to write the equivalent amount in a newspaper every day. So we simply don't have time to check our facts. We just come out with what we think of, what's our usual way of dealing with the topic. So don't criticize, just back off. We're doing our best. The other one said, which I also thought was quite interesting. He said, the media is not fixated with mental illness, but it is fixated with violence because people will pay good money, to read stories about violence. And it is a public interest. And so if there's any connection between anything and violence, then that will come into the pot of what newspapers write about. And they say, well, we do think there's a connection with mental illness. Quite often in the courts, people are found to have committed offences and also be having mental health problems at the time. So that's why newspapers pay attention to mental health. But still, that's really self-serving. So if we think about the Time to Change campaign, a big campaign going on now for 9 years, funded initially by Comic Relief and Big Lottery, but more recently mostly by the government. And the team I work with here at King's College London has been evaluating the impact of that. And the good news is that we're finding slowly but steadily stigmas reducing across England in many ways. One way we've assessed this is to take press cuttings from 6 different newspapers across England every year. 3 are national newspapers, 3 are local newspapers, and we sort of go through page by page. We identify any stories, any features, anything to do with mental, psychiatric, you name it, and then we look into the nature of the content. And what we've seen over 8-9 years now is that gradually the percentage of all those stories which are stigmatized has been coming down, and gradually the percentage of the stories which are anti-stigmatizing has been going up. And indeed, last year, we found for the first time that there were more anti-stigmatizing than stigmatizing stories. And that chimes with my own sort of individual impression is that quite rarely these days you see the front page tabloid headline screaming psycho killer, and that the incidents still do occur, and some people who commit offences have mental health problems. Of course they do, but quite often it's buried on page 4 or page 5. It's a modest piece. Quite often it's fairly responsible, and it's not written anything like the sensationalised way that we had seen 10 years ago. And I think there's a number of reasons for that. Partly is the Time to Change campaign. But I think another thing that's been helping a lot are the Mind Media Awards. So each year the Mind charity runs a big sort of glitzy media evening. Prizes are given out for best student journalist, best sitcom, best documentary, and so on. And a lot of people in the media come to that and see people being rewarded for covering mental health in a responsible way. And indeed, at the most recent event a couple of months ago, it was very moving because Freddie Flintoff, the cricketer, was hosting it. Somebody who received a prize said this was very important for her because she'd had a friend who'd lost her husband to suicide. And then Freddie Flintoff said, well, I've lost 2 mates in the last year to suicide as well. So you see that this affects everybody, well-known or not well-known. And I think the media getting rewards and recognition for responsible coverage is also a very powerful effect to help media coverage improve over time.
One last question I've got before we move on to kind of how you guys actually study this stuff is, are you familiar with the work of Mark Schaller and this concept of the behavioural immune system?
No, I don't know that, I'm afraid.
Right, okay. So very briefly, he proposed this theory that because we can detect explicitly whether or not people we come into contact with might be infected with a particular virus or bacteria, that we have this like a batch of psychological mechanisms kind of using our senses to take certain cues from the environment and from the person themselves as a way to assess whether or not they might pose some sort of contamination risk. And that if we do pick up on something, it results in a sort of disgust mechanism that makes us want to avoid the person. Apparently, it's been shown that this mechanism contributes towards prejudice against people who are overweight, people with disabilities, and elderly people as well, I think. So I'm just wondering if this maybe extends to people with mental health issues as well, that if we know or hear that person over there is mentally ill, quote unquote, that maybe we then fear, like consciously or unconsciously, that we might catch it. So I guess that was a very long-winded way of asking if some stigma can be explained by a kind of a fear of contamination, maybe.
Yeah. Okay. Yes. So, is there a popular fear of contamination? So let's start with the many different types of community in just living in England at the moment, for example. So I think there are a number of, if you like, popular, I'd call them myths or misunderstandings, which are commonly found. I'll give you an example. One is that you don't talk to a depressed person because that brings you down, that makes you depressed. So there's a sort of emotional contamination. So it's not to do with bugs jumping around. It's just that sort of, the bad mood sort of seeps across like a sort of horrible treacle, and it envelops you, and you're brought down and you can't stop it somehow. Now, of course, that's nonsense. And we know that the best thing you can do is to offer support and to offer to talk, to try to engage and have a good chat about things. But the myth itself is directly counterproductive because it's stopping people from wanting to talk, not just because they think they won't help the other person, because they think it might actually make themselves worse. The related thing to that, which I think is also extremely unhelpful, is the idea that you don't want to talk to a person who might be suicidal because you might trigger it off, and then you would be responsible or held responsible for that person's death. And of course, the opposite is the case. Very commonly, what people need is someone to talk to show concern, to offer support, maybe to be a link with getting other help or professional help. So that myth of you don't talk to somebody in case you trigger it actually is the last thing that you should be doing. So I think there are some of these ideas. But I think if we take other communities and look at religious communities, there will be people in many types of religious and faith community who would see an important spiritual component to mental health issues. Indeed, they might think that mental health problems come about from a lack of prayer or the wrong prayer or insufficient prayer, or by the influence of a spirit, or in the Muslim world by a jinn. So I think there are a lot of if you like, explanatory ideas around, and you can't ignore them, and for many people they're very important. We have to try to understand those, and at the same time say support and talk and sometimes treatment, maybe psychological, maybe medication, maybe some other types of treatment, are available and are effective and can go in parallel with support from faith communities as well.
Okay, I'd like to move on now to kind of how you... I can imagine the listeners now are wanting to know, like, to get into the thick of how it actually affects people, and I'm going to get onto that, but I really want to kind of lay the groundwork before we get there. I'm interested now in how you guys actually study this, and you kind of mentioned one briefly about taking like newspaper cuttings to kind of measure the media depictions. But what are some other ways that you study stigmatization?
So let me give you a specific example, Danny, which is the way we've tried to assess if this national campaign in England called Time to Change is actually working.
Okay.
So the starting point is the thing I mentioned a little while ago about splitting up stigma as a big thing into three specific areas, namely knowledge and attitudes and behavior. So quite often then in the studies we do about stigma, we're measuring knowledge and we're measuring attitude separately and we're measuring behavior separately.
Right.
Now, it seems to me that the most important is the behavioral area, which is the discrimination. So although I think it's important to know what are the general public thinking, what's more important for many people is, will I actually get that job? So I think we give most emphasis to the reports of service users about whether their lives and their experiences are getting better or not. So because of that, we had to develop some new scales. There's new ways to find out about these things. And we developed a thing called DISC, which is Discrimination and Stigma Scale. And the way that works is that the person undertaking the interview sits down with a person with experience of mental illness and asks for their views and then records their views directly. So it's a service user sourced set of information. It says things like, have you been treated unfairly, in your workplace when applying for a job? Have you been treated unfairly and going to see a GP or people in primary care? Have you been treated unfairly in any aspect of housing? And then you get a profile about how common these difficulties are, how severe they are. And then what we've done each year is to phone up 1,000 people across England, people who are in contact with mental health services, and go through these questions. And then we can see over time whether the reports of service users indicate that stigma and discrimination are getting worse or better. And to our surprise, for example, in the first 4 years of Time to Change, we found that people reported 11% less discrimination than they did at the start of the campaign. Now, it'd be nice if everything's getting better and it's a very simple and clear picture, but again, life's more complicated. And we saw, for example, when the disability living allowance changes came in, that a lot of people with mental health problems had a great difficulty in connecting the old benefits with the new ones. Some people were disallowed, had to appeal, maybe appeal several times. And that caused them a great deal of difficulty and stress, which they reported as discriminatory in relation to welfare benefits. But overall, the picture has been discrimination improving over that period. So we measure knowledge and we measure attitudes and discrimination, but it's service user reports of discrimination that we see as the most important part of the whole evaluation.
Do you have to take into consideration, I suppose, when you're asking people whether they've been discriminated against, there's an element of what they perceive as opposed to maybe what's actually taking place. I suppose the best way to articulate this is that, even if people are prejudiced, prejudice doesn't always necessarily translate into discrimination. And So say when you're asking people that are people with mental health issues, if they've experienced discrimination, there's a level of interpretation to be had there that they may be wrong about. They may not have been discriminated against. It might just have been their perception of the situation. So do you do any studies which involve people that are maybe engaging in discrimination and then asking them why they do so? And is that possible? Or I don't know if I've articulated that well enough.
Okay. So this is a fascinating question, Danny. When we started doing this work to assess discrimination, we were debating these issues, and we came to the point of saying, well, who can say what's real discrimination or who's not? Except that what's the strongest type of statement is the experience of those people at the receiving end of discrimination about what's happening. So we gave primary attention to that. Now, some people said, well, if somebody's paranoid, they'll feel they're being, not treated fairly. So that wouldn't be a fair assessment if that person said, yes, I'm being discriminated all day long. So when we developed this so-called DISC, the discrimination scale, we added a couple of questions at the end to the interviewer and said, for these 30-odd questions, for how many, if any, do you think that the answer might be influenced at all by the person's mental condition or their mental state?
Right.
We found that the average has been between 0 and 1 of those 30 questions.
Okay.
So we didn't think that was a major influence. In fact, we thought that was far outweighed by paying respect and paying a lot of attention to the direct views of people with experienced mental illness. Because quite often they're not. There's some experts saying something about, what's real discrimination. So we give that as the primary source of information. But there's another aspect that's actually quite important. Because for a person to say, I have been discriminated against, suggests that they have either experienced or they can imagine a world in which there's no discrimination or there's less. Or they can imagine that they should be treated more fairly. And there's a gap, and they think that what's happened to them is wrong, and they'd like to state that, and they should be treated better. But there are some situations where trying to know about a better and a fairer way of being treated is actually very difficult. So I'll give you one example. I was training some colleagues in an Eastern European country who were assessing discrimination. And this assessment didn't seem to be working very well. And so I went to discuss this. And it turns out that, especially among people who've been in a psychiatric hospital for many years, many of those people couldn't imagine any other way of living. So when they're asked, are you being treated fairly or not, with what could they compare their current situation? And they couldn't imagine any other life. So they simply didn't know if their treatment was fair or unfair, because that had been their life for many years, and that's what they expected every day. So I think it does presume that people have a sense of what's either right or fair or shows justice. And some of the demeaning, sometimes dehumanizing ways in which people with mental illness are especially kept in long-term institutions may actually make that sense of a fair life very difficult for some people.
And what about from the other side, the people kind of doling out the discrimination, for want of a better term? Is there any way of, conversing with those people and finding out the nature of the prejudice and where it comes from?
See, to some extent, it's not the same, but it's similar to racism. And the entire effort, or the large part of the effort in the last few decades in Britain, has been to stop the public manifestation of racism, so that it's unlawful to make racist comments or actions. Now, but you can't actually stop people thinking things.
No.
So what they might know, or their knowledge or their attitudes might be racist. But to some extent, that doesn't matter if they're not acting or behaving in a racist way. Now, clearly you want no knowledge and no attitudes and no behavior that's racist. But the important thing in terms of what the law and also what the state can do is to stop the behavior. And similarly, if we think about the mental health sector, is that, a lot of people might be fearful or anxious or, show disgust, whatever. But if they're still treated, but they're for an employer and they're giving an applicant a fair hearing when applying for a job, then that's less important. But let's come on to a practical way. So under the Equality Act, it's now unlawful, at least in Britain, to inquire about a health problem, and this means physical or mental health problem, either at the job application stage or at the job interview stage. So you should be treated fairly because that information doesn't come into play. Now, if somebody does have a health condition, quite often they'll be at the next stage if they're offered the job, but that might be picked up at the occupational health check or even the occupational health assessment. But it means that the law has sought to outlaw discrimination on health grounds. So I think that's a step forward. Now, it's not as simple as that, and that's not solved the problem, but that's a clear advance over somebody not being shortlisted at all. If there's a section on the form saying health problems, it says psychiatric treatment, and they're not shortlisted. So I think we've seen some progress there.
Right. So I guess it's more important that as long as you're seeing those figures reducing of stigma overall, it's not necessary to try and dig so far down into the details. I mean, at least on the side of people that are committing discrimination.
You see, I don't think that. Let's take a situation where a person with experience of mental ill health feels discriminated against, in a one-to-one situation. I don't think it's common that the other person is sitting there deliberately thinking, now I'll discriminate against the person. So I don't think it's malevolent. I think it's largely because they're not aware that what they're doing can cause offence. So somebody might say, oh, he's mental, and not realise that another person in that situation who may have had mental illness could take offence. But it's not meant unkindly or harshly. So I think it's lack of knowing the implication of what people are saying rather than it deliberately being a sort of intentional harmful act.
Yeah, I think that's quite an important thing to point out, actually, isn't it? Because I think stigma can often be misinterpreted as that, as people just being nasty and just being malevolent, when it's, I'd guess more often than not, it is just down to misinformation or no information.
So let me give another example. So when we started the evaluation of this national anti-stigma campaign called Time to Change, there had been, just around that time, an interesting survey by something called the Shaw Trust. And the Shaw Trust is a charity that does work related to employment and employers. And they'd actually done a survey asking employers about people with mental illness in their organizations and if they had any policies or practices to help. And to my amazement, this would be about 2007, 2008, they found that 30 or 40% of employers said, no, we don't have any policies because we don't have anybody with mental illness in our organization. And so it's an astonishing degree of ignorance. So they weren't deliberately saying, we're discriminating against these people. They just said, no, we don't have that problem. Next question. Now, interestingly, we did this follow-up to that survey about 3 or 4 years later, by which time there had been lots of activity to support employers to recognize these difficulties. And it dropped down to about 10% of employers then said they didn't think people in their organization had mental health problems. And the number of people who had policies or procedures like so-called employee assistance programs had gone up a lot. So I think part of the question is simply making people aware about just how common mental illnesses are everywhere, whether you're in a school or a college or a workplace, and that the treatments are effective, and that the treatments are widely available, and that for many conditions there's a choice. You can choose whether to have psychological treatment or medication or some type of social intervention, and that it's for the large majority of people on a sort of going to an outpatient clinic or to a community mental health centre and try and get away from the idea that any contact with a psychiatrist means you're going to be locked up and sort of have done things against your will.
Now that we're on it, kind of sticking with the employment aspects of it. So I've read a couple of the studies that you've done, and some of the effects, some of the effects that people experience as a result of stigma in the workplace. Lower rates of hiring, lower pay, more often sacked, and poor promotional prospects. My own personal experience, so when I was at the worst with my anxiety disorder, I had a driving job at the time, and I had to jump before I was pushed, basically. Because the fact of the matter was, as a result of that disorder, which I didn't have when I first started the job, I was becoming an unproductive member of the team. I wasn't fulfilling my obligations in the role. I was becoming unreliable, very flaky. And just from that perspective, is it ever fair? Is discrimination ever fair on the part of the employer?
So the answer is yes. So first of all, what do I mean when I say discrimination? Well, I use it as a shorthand for what is more properly called negative discrimination. Now, when we started to look at this issue, when we started to measure it with this scale to assess discrimination, we initially said, have you been treated differently because of your mental illness, in seeking a job? And the scale went from yes, much worse to yes, much better. And then we said, well, we don't presume about whether discrimination will be in your advantage or, against you. And then we did this, we assessed people actually in this sort of early version of the scale in 27 different countries around the world. And we found very rarely, in fact, hardly ever, did people describe any positive discrimination. And in fact, the only areas in which people did say that having mental illness had actually helped them was either they've got a bus pass or some sort of free travel card, or sometimes if they got quicker access to housing, if they were sort of homeless and mentally ill.
Right.
And also to some extent, getting support from family members. But across the board, 90-something% of all the experiences of discrimination were negative ones. So we dropped all the advantages side of the scale, just to simplify it. We just said, tell us if discrimination has been against you in these particular ways. Now, so when I talk about discrimination, I'm using it to say negative discrimination. But of course, discrimination simply means, to differentiate A from B. And it doesn't necessarily have to be negative. And indeed, on some occasions, to come back to your question, Danny, it is reasonable and fair to discriminate against a particular type of situation or behavior. Now, this isn't reasonable or fair to discriminate against a person because of a diagnosis, but let's say somebody's on a drug which is moderately sedating, and, let's say that they've tried different tablets and this is the best balance between the positive effects and negative effects, and then they apply for a job as a train driver. And then perhaps they're given a performance test and they're a bit slow to react when the brake warning light comes on or something. In that situation, I think it would be fair to discriminate against that person, saying that you are not fit for this particular role or task, not because of the diagnosis, but because of that person's task performance, their actual skills. So I don't think it's right to discriminate by virtue of any label, like depression or schizophrenia or whatever. But I do think it's right to say that some people with mental illness, in some circumstances, may not be able to fulfill particular roles and therefore be refused those particular types of job.
Yeah, it seems a tricky one as well. It seems a bit of a paradox in the way of informing people, because on the one hand, I think like with things like depression, people can think that people that are struggling with depression are just sort of malingering and they just need to buck up. So the message there needs to be that no, this really can be a really debilitating illness. But then on the other hand, we also need people to, especially employers, to understand that people can have a diagnosis but still function perfectly well in the workplace. And that seems like a bit of a tricky thing to weigh up in the message, I think.
Well, I think, so let's imagine that you or I were an employer. And if we think back to this survey we mentioned a moment ago by this charity called the Shaw Trust, in fact, 10 years ago, it was very common for bosses to say, no, I'm not going to knowingly employ somebody with mental illness because they're unreliable, they'll be off sick half the time. But it's the knowingly employ bit, because of course, up to a quarter of all employees will have mental health problems in a year, because everybody does, because it's so common. And for them to think that they can sort of selectively not employ people with mental illness and therefore not have it as a problem in their workplace is wrong, because everybody can, and sooner or later quite a lot of us do develop mental health problems. So they can't just stick their head in the sand saying we won't take those people on and we'll just get on without it. And there is a huge cost, not just to the individual and their families, but to the workplace, if you either have people off sick without getting help, or have people carrying on, still trying to do their work, so-called presenteeism, not absenteeism, but under par. But even going beyond that, there are quite a lot of people who actually are not feeling very well mentally, still going to work, masking and hiding it very successfully, perhaps going home in tears, but soldiering through the day without showing their feelings. And that doesn't add to that person's well-being. Maybe they're managing and working, invisibly, but they may be even more productive if they had their difficulties addressed and helped. And they may even show more loyalty to the firm if they actually got help, from the employer as well as outside. So that you find that there's not just a question, if you like, of an employer saying, well, I'll get rid of people who've got difficulties. There are huge costs with them if they were sacked, for example, in having to re-recruit, retrain, get this experience of new people as well. And it's much simpler and quicker and more efficient, as well as more humane, for employers to actually look after the health of their employees and to help those who become unwell get through that and recover, because it happens to virtually all of us at some stage.
Yeah, good little segue into another issue which you've raised as well, is this on the part of the employee, this dilemma of whether or not to disclose their mental health condition. I don't know if there's any way of answering this broadly. It seems like something that's better assessed by an individual on a case-by-case basis, but is there any kind of broad advice that you could give to people about whether or not they should disclose their condition to an employer, or to anybody for that matter?
So let's first of all look at the extremes. A situation where somebody is feeling extremely unwell mentally, thinks that maybe their personal relationships, maybe their working situation, their friendships would be damaged if they said anything to anybody, and that everybody else would talk and gossip would get around, and therefore doesn't say a word. So the downside is they don't have direct, if you like, reputational damage, but nor will they get support, sympathy, empathy, maybe help to get to treatment, and they may actually continue to be unwell for quite some time. And other people don't know, if they're hiding it successfully, that help is needed. Now let's take the other end of the spectrum to start with. Somebody who's very open, speaks with everybody, tells whoever is passing by, I've got depression, whatever. And quite often they will get negative reactions from others, because still stigma, let's say in England now, is very common and sometimes very strong. So first of all, one can't generalize. There's not an answer that would apply to anybody. So let's take the example of a person applying for a job. So I wouldn't say it's a question about do you disclose or not, but much more a question of, if you want to disclose, then thinking about something that's called conditional disclosure. That would mean, well, would you say something, and when, and to whom, and how much would you say, and with what safeguards? So again, let me give an example. The patient I've been treating recently, a young woman with some psychotic symptoms, and she had a job and then was off sick from work for about 2 or 3 months, and then said a little bit to the boss about some mental health issues. The boss reacted actually quite positively, but not too much detail, and then discussed with the boss in a bit more detail what had been happening. The boss said, fine, you'll have a graded return to work. And the woman then said, but, I don't want you to tell anybody else in the workplace. I will decide what I say. So she was managing different information to different people, sort of on a need-to-know basis. And then went back, and in this office, most people said, oh, hello again. A few then said, where have you been? She said, I've had a career break to think about the future, which was actually true. Now, it wasn't a voluntary break because she'd become unwell, not of her choosing, but she had had a career break. She had been thinking about the future, and so it wasn't a lie, but she didn't say anything about mental anything. And then the couple who had actually inquired about why she'd been off said, oh, all right, good to see you back, and that was it. So in fact, there wasn't, any great probing or need to know. She'd made a true statement, but a bit of the truth. And then she got back to work and carried on, and gradually went from 2, 3, 4 days a week and so on. So I think one approach that may be helpful to some people, again, I'm not generalizing, is to think carefully about conditional or graded disclosure. And particularly, if you can, to do some rehearsal or practice. So before you go back for a return to work interview, go out with a friend or a mate or somebody else and say, now just let's run through it. Let's have a practice like a mock interview so I can get the storyline straight. So another example is a young man I treated a few years ago who wanted to find a girlfriend. So he would do it in small steps. So first of all, he might be sitting somewhere and he'd be reading the newspaper. And he would say to her, oh, look at this, story in the newspaper about a mad killer. Now, if the young woman, in this case, said, oh, you shouldn't believe everything you see in the newspaper. My mother had some depression. Most people aren't dangerous at all. Then a bit later, he might say a bit more. But on the other hand, if the young woman said, yeah, they're all crazy, you've got to be careful, every corner there's somebody lurking. First of all, he wouldn't say any more. And perhaps, indeed, that's maybe not the the woman for him. So he then deliberately took a sort of small step at a time, toe in the water. And then it did as a progressive but quite slow gradation of saying more about his own situation. So that's another approach. But I think you've got to sort of work it out yourself. And of course, there are big risks as well as big benefits, which might follow saying something to somebody else.
Yeah, it sounds almost as though, I don't know if this is already something that has been implemented, but as a way of tackling stigma, not just kind of trying to inform the public, but in, I suppose maybe as part of CBT therapy, in training people to navigate that part of life. Is that something that's already done? Or, and if not, is there anywhere somebody can go to get advice about that? It sounds quite an important thing to learn for people.
So, how do people, know how to go about this difficult question about concealment or disclosure? Well, I think talking it through with friends in advance. We've actually developed here at King's College London something called a decision aid tool. There's my colleague, Dr. Claire Henderson, who's been doing this. So we actually have a sort of form you can work through, if it might be with a nurse or with a doctor if you're receiving help or treatment. So you can actually decide in advance what you want to say, how much or how little, when you might say it, if you'd volunteer it, or only say that if you were sort of indirectly questioned, and with what safeguards. So you might say to a boss, as I mentioned, I'd like to tell you, but this is in confidence and I don't want everybody in the workplace. Or you might say, and I'm formally applying for reasonable adjustments under the Equality Act. What this means is, you've broken a leg, go back to work, then you might say, well, I'd like a lift or stairs or escalator. If somebody's had a mental health problem, they might go back and say, well, I want 2 weekly supervision, not monthly. I want to be able to travel off peak times because traveling in crowds makes the anxiety worse. I'd like to be able to use headphones because noise, I'm sensitive to noise at the moment. So people might then have particular conditions that they'd attach as how they would find it helpful and supportive in the return to work phase.
Right. Okay. So we've talked a lot about employment and I suppose we've kind of skipped over some of the other more kind of obvious factors that result from stigma. Things like the consequences from, say, family and friends, and people are going to lose friends. It's going to affect relationships. I feel like those are kind of fairly obvious consequences that people are kind of going to have a fairly basic grasp of anyway. But I just wondered if there was anything that you feel is worth kind of adding to that part of the discussion that's maybe not so apparently obvious.
Well, the thing is that stigma is a type of polluting cloud that just gets everywhere. And it interferes with, very many aspects of the lives of people who either have or have had mental health problems. So let's take one example, which is getting access to physical health care. So let's take a specific instance of somebody who goes to a casualty. They've got really bad pain in the tummy. And the doctor, first of all, goes up to the computer to see if the person's been in before and any medications or anything, and then says known psychiatric patient. So before they even talk to or examine the person, they've got this sort of expectation that this might be a psychiatric or a psychological problem. And they're more likely to then say, it's in your mind, or you're anxious, or, don't worry me, it's not a real problem. Brackets, you're a malingerer. Now, you might think that that's a bit harsh, and that these people in casualties, or maybe also in primary care in GP practices, are trained not to do that. But the evidence is to the contrary. So there's a lot of evidence now that people who have mental illness and who have a physical illness get second-class physical health care. And so let's take one example. This is a study of people in the United States who had a heart attack, so-called myocardial infarction. And there's a big study looking at what happened to people who had a heart attack according to whether they also had a mental illness or not. And in fact, they found big differences, because the people who also had, as well as the heart attack, a mental illness, then were investigated less, and they had less active treatment, and the death rates are worse. So I think this is one clue to why we find that the life expectancy of some people with mental illness is actually lower than the whole population. So one part of it is that they're getting, when they do go for physical problems, they're getting worse physical health care. And I'd see that as another aspect of stigmatization, that they're not being treated, that their physical problems are not being treated on their merits as you'd expect for anybody, whether or not they had any other condition. Now, again, this is not a trivial thing, because we're seeing severe illnesses going either untreated or less well treated, physical illnesses, but also because, especially in middle-aged and older people, it's now common in many countries of the world that they have 2 or 3 or 4 long-term health conditions altogether. So, for example, it might be high blood pressure and depression, or it could be diabetes and depression and rheumatoid arthritis and depression. And increasingly, we're seeing older people have a mixture of long-term conditions. And either we're seeing people with mental illness having their physical health care needs neglected, or we're seeing the opposite, which is people might have rheumatoid arthritis, they go to see their GP or the rheumatologist, but their mental health needs are not being asked about to see if they have, for example, a depression. So that wouldn't be inquired about, it wouldn't be detected, it wouldn't be treated. And in fact, if you have a long-term physical problem, you're twice as likely to be depressed as the next person.
Yeah, of course, yeah.
So it's that so-called comorbidity. This is conditions occurring at the same time, a physical and a mental. And whichever direction you look, then you're finding people with mental illnesses are being short-changed.
Wow. It's a bit of a tricky one to kind of know how to tackle that. It sounds almost like there's a good argument there for why maybe people should seek mental health treatment separate from the GP, in the sense of, by you go to the GP and you've already got a pre-existing mental health condition, then, you risk being accused of malingering, and, there's nothing wrong with you. It's just anxiety. Anxiety causes all sorts of funny symptoms. But yeah, on the flip side of that, a doctor needs to know about the mental health issues you face, because they have kind of a direct, a somatic impact on you as well. What do you think is maybe the answer to that? How do we fix that problem?
Well, the usual answer is to talk about something called integrated care, which means some way of trying to identify for any particular person the whole range of needs, whether it be physical or mental, and then making sure they get the right treatment. But that's much easier said than done. So, for example, where I work, which is a community mental health team in South London, for a long time we've hoped that people's physical health care needs would be done by the GPs, and we'd focus on the mental health care. But for a whole range of reasons, quite often that doesn't happen. So we've now decided that in this mental health clinic, for the patients who come to see us, we also offer physical health care clinics. And we check body weight, smoking, blood fats, all that type of thing, because we think that it has to be done, and that at the moment it's easy for the system to think somebody else will do the right thing for the other part of the picture, the mental or physical, but that may or may not happen. So I think it means different solutions, but as long as we're sure that whatever a person's whole needs are, that somebody, either one place like a clinic or maybe a joined up system, is ensuring that all of the needs are checked, they're identified, and all the treatments are actually being delivered properly. And it's easy to think that somebody else should be doing something else without checking, and in fact they're not. And the consequence is neglect of some part of a person's healthcare needs.
Okay, so moving on now, I'd like to kind of go back over something you mentioned at the beginning of the interview, was this concept of why try. I think it's referred to as self-stigma. And if you could kind of just briefly explain some of the problems that arise from that, because again, that, like you say, that's a problem that's not immediately apparent under this umbrella term of stigma.
Yeah. So there are several parts of the picture here floating around. Sometimes it's called self-stigma. Sometimes it's called internalized stigma. But let's try and see what's happening. So if I'll give you again, start with an example. So when we were doing a study a couple of years ago here in South London about people's experience of discrimination, I then sat with a man here at the Maudsley Hospital, and one of the questions was, since you've become unwell, have you been discriminated against in applying for a job? He said, nope. So I said, well, since you became unwell a few years ago, have you applied for a job? He said, nope. So I said, well, why not? He said, schizophrenics can't work. And he said it in a very sort of rapid staccato way. So I said, well, can you tell me more about that? He said, everybody knows people like me, schizophrenics, we can never work again. So he had somehow picked up the idea that the diagnosis that he had permanently rendered him unemployable and unable to work. And so he had therefore decided not even to apply. So he'd internalized some picture of the life chances and the future of somebody like him because of one characteristic of all of the many talents he had, namely the diagnosis that he'd been given. So that had a very powerful and negative effect upon him. No, I disagree with him. I don't think any particular diagnosis does or does not, in mental health terms, mean you can't work now or can't work in the future. But for him, that was a powerful and negative force. So I'll give you another example, which is, a couple might say to their doctor, let's say one of the couple has a mental illness, we'd like to try for children, but we're not sure because we don't know if the children will be affected. And sometimes doctors will say, you must be very careful, and of course the children might be affected, and I really couldn't advise that, which would be a misleading statement because where there are genetic aspects as part of the picture of having a mental illness, often they're very weak effects, and the much greater question is whether something in your life is upsetting or a shock or a trauma to you, or even that, we actually don't know the causes or the likelihood of somebody, let's say the child, developing a future condition. So, but sometimes these, sometimes quite patronizing, even if they're well-intentioned statements from authority figures like doctors, can really limit a person's life and leave them much less able to participate in the community than they otherwise would. Yeah,
it becomes like a self-fulfilling prophecy. I guess, I suppose it expands beyond that, though. I suppose in just, not just from like a career perspective or something, but just this idea that, there's no point in me going trying to make friends. I'm not well enough. There's no point in me trying to go out and have any hobbies. There's, that idea can completely shut somebody down, which is then obviously just going to cause a downward spiral that's going to exacerbate the problems that exist there anyway. So, okay, before we kind of get to wrapping things up, I think one important and quite prominent aspect of mental health stigma at the moment, something that's quite fashionable in the media, is this kind of almost the war against stigmatization for men. That's kind of seen a lot of stuff about that at the moment. I was just wondering if what are some of the specific challenges faced by men with mental health issues when it comes to stigma?
Yeah, so let's look again to start with a specific example of this is a man who was the captain of the New Zealand rugby team and who towards the end of his active playing career himself had quite a severe episode of anxiety and depression. And he then, after his treatment and he was feeling better, came out and made quite a few statements and films about what had happened, saying that not just in the rugby world, but in the male world, there's a sort of macho culture where, a real man is strong and tough and doesn't really talk about feelings and certainly doesn't show weakness. And in particular, that in the sports and in the athletes world, you have to be sort of top fit peakness and you're competing and, any sign of weakness and you're dead and you're not competitive. So he was saying this is actually nonsense because these things happen to everybody. And interestingly, in the sports world now, there's an attempt to sort of switch that around. In fact, a lot of cricketers and some footballers as well have been coming out about the experiences, and also in recent months, several boxers and athletes. And you don't simply say, you mustn't admit weakness. You can actually switch it and say a person, but also a team, can only really perform at peak fitness or compete at top competitiveness if they're fully fit in mind and body. And if there's any difficulty they're having, either a physical injury or a mental difficulty, then they're not going to be performing at their top level. So you have to pay attention to the whole person, emotionally, socially, mentally, and physically, to allow that person to do their very best. So, and that's, you see quite a lot of psychologists now working with, for example, football teams and also with tennis players and so on, to try and get that fine tuning. So I think we're seeing a greater recognition about how, even among male culture, it's not just important, but it's actually also good for their performance as well.
Do we know if these recent mental health campaigns specifically aimed at men, do we know yet if they're actually having any kind of impact?
So the most recent focus on the time to change, we haven't evaluated that per se, but what we have done in previous waves is to look at where the campaign was focused on specific target groups. So, for example, in one of the years, Frank Bruno was one of the champions. We know that in that year, there's a greater response in stigma reduction among black people who were surveyed. And also we know that in the subsequent phase of Time to Change, this is the national anti-stigma program in England, there's a particular focus on young people, again, where they responded to material, films and so on, particularly targeted towards that segment of the population. So I don't know specifically for men, but we know from previous experience it's likely that if you do target specific information, it's likely to succeed. So Time to Change in the last year or two has done quite a few films. One is of two men talking, and they're having a cup of tea. They're sitting in the kitchen, and one's saying that one had helped the other, and the second is saying he'd received help and, it mattered to him. And it's only right at the end of the film, which is a short film, that the man who had received help mentioned that he had been suicidal and he'd been on the point of taking a very big overdose when he's had a chat with a friend, which had actually probably stopped his death. And so you get the real impact of that nature of the disclosure and of the importance of talking, which can save lives.
Yeah, I think just from personal experience, I have to say I've been quite impressed with some of the campaigns. Particularly, there was one with I think it's called Jamal Edwards, the guy behind SBTV, which is like a popular YouTube hip hop channel. So he was going around talking to UK grime and hip hop artists about mental health, and I really like that campaign because I think particularly that kind of culture, if you've got rap MCs are saying it's okay to talk about this stuff, then I really do think that's going to have an impact, particularly on young people. It's like, well, if those guys are talking about it, then maybe it's okay to talk about. The one thing I do think is missing from this particularly these campaigns aimed at men is so from personal experience, it doesn't matter to me whether anybody could come on. So say someone like Jay-Z. To me, Jay-Z is like God. I'm a huge fan of Jay-Z, and he could come on TV and he could say, that he had mental health issues. He could come and visit me in person and he could tell me that he had mental health issues, and that it's kind of okay to talk about it. But for me, my issues were around anxiety, and even saying that now to you, it makes me cringe every time, this idea of being anxious, and this idea of being, it's like it's okay to talk about it, and that society's stereotypical views of masculinity kind of don't apply. None of that really appeals to me, and I think there's a certain subset of guys like that who are like me, that the message, we don't want to hear the message that we kind of need to change our views of what masculinity is. Masculinity can be completely subjective. It can mean one thing to one guy and that's fine. But to me, it means a very specific thing, even if that does mean that it kind of conforms to the stereotypical viewpoint of masculinity. And telling me that I need to kind of get rid of that, that's not going to work for me. I feel that, I want to know that I can go to a therapist and repair that. I can take that sense of masculinity into the therapist with me and work on that, and that's going to be okay. And I think another thing is what appeals to me more than this idea of kind of sitting down and talking to somebody is having a therapist that is going to be somebody that's going to give me tools to kind of get over this, someone that's going to kind of help me through it. I don't necessarily want to sit down and talk about it in that sense, but just someone that's going to help me be proactive and get through this, if that makes sense. I don't know if you've got any thoughts on that, but I just feel that that's kind of there's a subset of men, probably like myself, that are being maybe missed with those campaigns.
So I think these are all really important points, Danny. So, no two people are the same. And when, for example, the Time to Change campaign says it's time to talk, that doesn't mean everyone's going to be talking all the time and everybody's disclosing everything and it's all in public. So for some people, they're quite comfortable to make, public statements. Many people, probably most people, are not. But on the other hand, there may be other ways to talk without talking to many people or without even taking any risks in terms of disclosure or, loss of reputation or status. Mm. One way is to do it, for example, in terms of, confidential relationships with a therapist or a psychologist or a psychiatrist or nurse, whatever, but where you can speak openly, but have a strong degree of trust that, other people are not going to find out about that.
Yeah.
Another way is to do it, through aliases online. So there are a lot of forums where people do share information, get enormous amounts of validation support, but their identities are concealed because they choose to use another name or, a handle or something. But nevertheless, they're getting direct contact of people, quite often who have other similar experiences. That may be ongoing, it may be in periods of crisis. And so there's, and within that, again, anonymized framework, people might be very open about exactly what's happening. Indeed, in times of crisis, they might actually get enormous support from complete strangers who they feel they know very well, but they don't know their names. So there are degrees of protection you can build in and maintain, your outside world sense of being a man that's functioning and so on. But have moments of reflection or sharing, which actually are much more sort of healing or nourishing in other ways.
Yeah. Okay. One final question I think's worth asking is: does say these anti-stigma campaigns are successful as a whole? Is there a chance of kind of unforeseen problems cropping up precisely because they've been successful? Because what I mean by this is, you hear a lot about mental health services are underfunded and understaffed as it is. And obviously, if these anti-stigma campaigns are successful and that encourages more people to go and seek help, it seems that there's a possibility there that the services are going to be even more stretched and then even less effective than maybe they already are. And I'm wondering are we putting the cart before the horse in focusing maybe on anti-stigma being such a huge thing in the media at the moment, whereas maybe it'd be better to focus on kind of government funding efforts first. I'm just wondering what your thoughts are on that.
Yeah, it's a bit of cart and horse about, or chicken and egg here. So one way to think about this is thinking about, of all the people who have mental health problems, how many actually get any help at all. And you could talk about things that are stimulating demand, people going to the GPs, going to psychological treatment centres, saying, I'm not well, I need help. Or you can think about supply, meaning actually are there enough therapists and doctors and nurses and so on ready to receive and offer treatment to the numbers needing it. And it's always an uneasy friction. There's no point stimulating, through an anti-stigma campaign, huge numbers of people to go off to mental health services or even primary care services if there just aren't the numbers of services available and they'll be frustrated or turned away. On the other hand, there's no point investing in, at the moment, for example, large numbers of new psychology posts if people won't go there because they fear stigma. So you've got to try and do both at the same time. And the balance will never be quite right. There will be some friction. But generally, I think, in many cases in the British Health Service, demand drives supply. And when you've seen conditions which have become less stigmatized, for example, HIV, then services sooner or later have done the right thing and responded to better meet the needs of coming forward. So it's not the question of stimulating, supply or demand, but doing both at the same time. But the starting point is that so few people in this country, it's only a quarter of people who do have a mental illness are getting any treatment. So there's a long way to go, before we're actually fully supplying mental health services in relation to the level of need.
Right, Graham, are you super pressed for time, or because I've just got the philosophical questions, the kind of quick fire questions, but I want to be respectful of your time, of course.
That's okay. I've got 2 minutes till 4 o'clock, Danny. So whatever we can do in 2 minutes.
Okay, right. So I think my three most important questions that I run past everybody. So the first one is, what's the best piece of life advice that anyone's ever given you?
So I think I'd say that this was not, advice told to me, but it was the example. And this is my grandmother. And she lived to the ripe old age of 101. And every time I met her, really the only thing she would do would be to encourage me. And she never had a critical word. Now, she wasn't my parent, so it was easier, but that was a very important relationship to me, because she listened and she gave me positive feedback and she encouraged me every time we met. And so that was a very important part of my growing up.
Outside of family and academia, what investment of time or money has brought you the most joy or fulfillment?
So I, outside of work and family, I think that one of the things that I do, which is important, is to try hard to keep physically fit. And I think everything else that I do benefits from having more energy or feeling more positive in myself. And that when I, for different reasons, do less exercise, then I feel worse.
Okay, and finally, the big one. What do you think is the key to happiness?
No comment, Danny.
No comment. Well, I've not had that one before, so an original answer is always a good answer. Graham Thornicroft, thank you very much for your time. Is there any links on the web you'd like to recommend the listeners pay a visit to?
Yes, so I think the good starting point is to search for Time to Change. And there's lots and lots of materials there, and which are really, really good, about how to reduce, and we hope before long, eradicate stigma.
Okay, perfect. Graham, thank you very much.
Okay, all the best, Danny.
Okay, if you'd like to comment on this episode, you can do so by going to myownworstenemy.org/podcast. That's also where you'll find all the show notes and links to any relevant information. If you'd like to support this podcast, you can do so by leaving us a positive review on iTunes, or just sharing your favourite episode with your friends and family on social media. If you'd like to contact me, I'm Danny D. Whitaker on Facebook and Twitter, or you can send me an email to danny@myownworstenemy.org. And until next time, behave yourselves, but not too much, and I'll see you again next time.